Well, good morning, everybody. It's great to see that so many of you have joined us this morning. I'm Anthony Burns, and I'm a councillor in St Helens and the current Cabinet Member for Wellbeing, Culture and Heritage. I'm honoured to be here at this really important event. I'll be taking you through the programme this morning. But before we start, just a little bit of housekeeping. Firstly, we've turned off the facility for cameras and microphones apart from presenters, so please use the chat facility to pose any questions to each speaker as we go through the agenda. There's no set Q&A, so we will take questions after each presentation and we'll attempt to pick the most popular questions in terms of likes. We will then aim to answer as many questions as possible, but I would encourage each of you to please use the chat facility. There's no such thing as a bad question. Please put your questions in there, and the questions that we don't answer at the end, we will certainly capture. Also, we would ask if you could engage with the event by using our hashtag #HopeThroughAction. That would be great. We will have a break at 10 to 11 for 10 minutes to allow people a break from their screen. And just to let you know that the event is being recorded and will be available on the Champs YouTube channel. So on with this morning. So welcome to our annual No More Suicide conference for Cheshire and Merseyside. We have a really exciting programme for you today. But before I go into the details of the conference, I'd just like to take a few moments for us all to reflect on the last 18 months. Without a doubt, we have lived through the most difficult 18 months. We know the pandemic has had an impact on mental health and well-being of our population. The links with social isolation, loss of jobs and debt, furlough coming to an end, domestic violence and the long-term impact on families. The impact on children and young people and loss of education have all contributed to the burden. Alongside the individual impacts, the impact of trauma and bereavement on those at front line of services means we have a workforce that is also tired and is still working under considerable strain. It can seem daunting, and yet what this pandemic has shown us is how individuals, communities, voluntary services, public sector, schools, colleges, universities, and our business sector have all worked together to have a better outcome for our population. Creating hope through action is the theme of World Suicide Prevention Day 2021. And we all need to consider how we can contribute to this very important but very complex issue. We know in the depths of despair, hope sometimes seems very far away. And yet we know that little changes and collective action together can change despair to hope. So whilst we are listening to the speakers, let us all think individually about what we can do and how we can contribute to the new suicide prevention strategy, and how this doesn't have to be just a strategy wrote down on paper or on a screen, but a strategy of actions where we all take something away and do something about it. I should add that it is important for us all working in this area to look after ourselves too. So should you need any support whatsoever during or following today's event, please visit our No More Suicide website, which has a wide range of help and support. And you can find that at www.no-more.co.uk. We know the great assets that we have in Cheshire and Merseyside. Suicides are not inevitable. Together, we can drive forward our new actions and create a collective community of hope. So, onto the programme. We have some exciting speakers, and we will be ending with the opportunity for us all to start the consultation on the new Cheshire Merseyside suicide prevention strategy. Our speakers today are Ruth du Plessis, who's the Director of Public Health in St Helens, and she's also the Cheshire and Merseyside Lead Director for Suicide Prevention. And Ruth will bring us up to date on the suicide rates for us in Cheshire and Merseyside and our real-time surveillance that allows timely action and interventions across the area. Then we're pleased to have Michael Salla from Everton in the community and Professor Andy Smith from Edge Hill University, and they will be presenting the evaluation of the men's health work that has been ongoing in all the 9 local authorities. We're absolutely delighted to hear from our key speaker, Professor Rory O'Connor, the Professor of Health of Psychology, Suicidal Behaviour Research Laboratory at the Institute of Health and Wellbeing from the University of Glasgow, who will present on his latest book, When It Is Darkest, Why People Die by Suicide and what we can do to prevent it. We'll be hearing from Rory after the break. We will close the session with an opportunity for you all then to start to engage with us on what the gaps and priorities will be for the next suicide prevention strategy. And that's really important that we engage with you as much as possible. So I'm sure you'll find the conference interesting and informative. And with that, I would like to start by inviting Ruth du Plessis, Director of Public Health in St Helens and the Lead Director for Suicide Prevention in Cheshire and Merseyside, to give us an update on the recent picture of suicides in our area. Over to you, Ruth.
Yeah, thank you, Councillor Burns. Yeah, so as Councillor Burns has said, so I'm Ruth du Plessis and I'm Director of Public Health for St Helens Council. And I've recently taken over the chair of the No More Suicide Prevention Board. And I just want to give a shout out here to Sue Forster, who was the previous chair of the board, and thank her for all her support and her leadership. And I count it a real honour and a privilege that I've been able to take forward this role. And thank you for all your support with this as well. Next slide, please, Tracy. So our vision for Cheshire and Merseyside is that we eliminate suicide, and that's the line in our vision that always stands out to me the most, and it's very much our aspiration. We don't want any suicide in our area, in our region, and we want to be a region that supports people. We know that life has twists and turns, and this 18 months has been more than ever a twist and turn journey, and we need to be making sure that we've got the resources and the support for people in time of crisis, but also that we're doing everything we can to protect people from crisis as well, that we're building community resilience, we're supporting individuals, and actually in the background we're looking about how we can improve lives. And that, I think that vision resonates very much with me, and I hope it does with you too. Next slide, please. So, as Councillor Burns was saying, for me too, this last 18 months has, I think for nearly all of us, has probably been the most challenging of our lives, and for our society, a massive adjustment. And we do know that it's had an impact on mental health and well-being. We know that around things like isolation and depression, and we are sadly seeing some of those statistics with increasing rates of depression. We're seeing more young people than ever accessing mental health services. So we do know that the pandemic has had a really big impact on mental health and well-being. And actually it means the time is now, and it's so important that we're meeting today and we're discussing the way forward. I think the thing that has helped us to get through this has been that people have pulled together tremendously. And I've been privileged to see how different parts of our society, different services have pulled together. I'm thinking about Captain Tom and Joe Wicks and people who've volunteered at vaccination centres, people who changed their job roles. So people from our library services have been giving out food hampers and all things like that. And it's been crucial, that working together to get us through. And I think, just the tagline of creating hope through action. We can't sit around and do nothing. Change happens when we work together and we do things. And so that really resonates with us as well, that we can create hope and that together we can do things that really do make a difference. Next slide, please. So I'm just going to start talking through some of the data now. This data looks at the suicides and undetermined injury over quite a long time period, from 2003 up to 2020 for Cheshire and Merseyside. And you can see that Cheshire is the darker purple and Merseyside is the lighter purple. And I think what stands out to me when I look at this is 2010 was when we had some of the lowest rates. And we all know that kind of 2010 was when we saw the financial crash, some of the beginnings of austerity. And then you can see right up to 2014 that we were seeing a steady increase year on year in suicides across the patch. And then in 2015 was when we launched our strategy. And you can see over the last few years, we are making some headway in terms of a reduction in suicide and undetermined injury. But we've still got work to do in terms of achieving a greater reduction. Next slide, please. This slide looks at rolling averages. We use rolling averages just because there's a lot of variation. So if we want to draw trends and things, and this looks at from 2011 to 13 rolling average up to 2018-20. and looks at how Cheshire and Merseyside compares with England. And you can see kind of 2012 up to 2016, that time, and for quite a few years, that Cheshire and Merseyside, you know, we had a problem. We were higher rates of suicide than England as a whole. I think you can see that although it looks like our decrease has been a bit slower than it would have liked to have been, that while we've been decreasing, that actually the rate in England has increased. So I think that evidences the level of work that we have undertaken. Some of this is a dotted line, and I do have to say as well that some of the data for 2020, there are some caveats around it. You'll be aware with the pandemic and everything else that actually data collection has been one of those things that I think has suffered. So some of these figures might change slightly as well, but as things are, we have seen that continued decrease. Next slide, please. This slide now shows you the rates by each of the 9 areas, each of the 9 local authorities within the patch, and how we compare to England and the North West. And the kind of the bar at the end is our confidence intervals. It's kind of saying, how confident are we that this is the real data? And what you can see is that no area in Cheshire or Merseyside is significantly different from England and the North West. So we're not seeing any areas with really high rates at the moment, which is something we are thankful of, but still got some more work to do. Next slide, please. So that was what I've talked through there is the data from the Office of National Statistics. And what we have in Cheshire and Merseyside is we have our real-time surveillance data, which is where we get data straight from the coroner's office and from the police. And we get that data sooner, which means that we can then look at the risk factors and other things that hopefully mean that we can act quicker and pick up any trends or any learning more quickly. And I think some of those things that we're seeing is that there are some variations in how COVID has impacted, and we're seeing some boroughs that have seen an increase in suicides and some have seen a reduction. So there are some variations. I've talked already as well about the issues with data collection, and we think some of the ONS data may be showing lower rates than actually they are, particularly Cheshire East and Warrington. The number that we have in our data is higher than the ONS data shows, so we think there are some delays in data. And even for us, even with our real-time surveillance data, we've had some issues this year that we hadn't had in previous times, again, just because of everything happening around the pandemic and all the different job role changes and everything else. And we've still got some more analysis to do, looking at, for Cheshire and Merseyside, that level of data, looking at kind of things like age and sex and method. I just wanted to quickly show you the St Helens data, because obviously I get to look at that data in a bit more detail, but it just gives you an indication of some of the risk factors that we're seeing across the patch. 75% were male. Most of the suicides occurred at the property of residents. It's a young age group. 66% were aged between 26 and 55. Over half were known to mental health services. Over half were unemployed at time of death. And we also know that 43% had either had a previous suicide attempt or self-harm. And we think those figures are going to be fairly similar across the patch. Next slide, please. This just shows you the data in Cheshire and Merseyside by month on our real-time surveillance, 2019 compared to 2020, just to show you there is a seasonal variation. Generally, you see some of your highest rates around April, May. But what we saw last year, and potentially with kind of the changes in restrictions, is that actually we saw our increase in suicides in July and August. So we wonder what impact kind of the coming out of lockdown and so on had on those figures. Next slide, please. This just shows you the cases by the last 2 years in each of the regions, and each in the local authorities, and you can see that there is some variation. In 6 of the 9 areas, the number of suicides has decreased, where it has gone up in 3. So we need to be looking at those different areas. But some of those figures may change as we get more data coming forward. Next slide, please. Just some of our developments, and I know many of you will have been involved in all of this hard work. We've got a self-harm practice with a C toolkit, which is for teachers and others, so they've got those resources. We've done an awful lot of campaigning, just getting the message out there that it's okay to talk and to ask people how they're really feeling. We've got the Stay Alive app. We've done a lot of training, for example, training for blue light services on first aid training, the Samaritans training on difficult conversations, self-harm awareness training. We've got the website, which we put all of our resources on, and it's just that useful one-stop shop where you can go and get what you need. I'm looking forward to hearing from Everton and the community about the evaluation of some of our men's health programmes. We've done a lot of work around dual diagnosis as well. We've also got the 24-hour crisis care line, so you can get help and support every day, 7 days a week, any time of the day or night. And for those who don't want to speak over the telephone, we've got a text service as well. And we've got the Amparo Suicide Liaison Service for those who've been affected by suicide. And that's now across all 9 local authorities in Cheshire and Merseyside. Next slide, please. And I think just kind of going forward, you know, we've had to all change an awful lot and learn a lot during the last 18 months, and we need to embrace those new opportunities. We're about to update the strategy, and I know Sue's going to be talking about that shortly. And again, I think, you know, we all know, isn't it, suicide prevention is complex. There's no one size fits all. We need a range of interventions to really make a difference. And we do that by pulling together and working together and taking action. And our heart is the same. You know, the most important thing is we want to save lives, but we want Cheshire and Merseyside to be a beacon of hope in England, and for us to drive forward those actions. Thank you very much for listening. This just highlights some of the many partners who are involved in what we do, so thank you.
Thank you very much, Ruth. That was a very comprehensive presentation, though. Well done in getting through it in a short space of time. Just to remind everybody, we do have the chat function if you want to ask a question of Ruth or any of our future speakers. We do have a few minutes if anyone has a quick question for Ruth, or if you think about it a little bit later, please still put it on the chat, even if we've moved on, and we will capture those questions at the end of the session and make sure that they're all taken on board. Okay, thanks very much for that, Ruth. So on to our next presentation. We're now joined by Michael Salla and Professor Andy Smith. Michael Salla from Everton in the community and Andy from Edge Hill University will be presenting the evaluation of the men's health work that has been ongoing in all the 9 local authorities. As I just said, if you have any questions throughout the presentation, please do ask them in the chat. And over to you, Michael and Andy. Thank you.
Thank you, Councillor Burns, and thanks also to Ruth for an excellent, very quick summary on the current state of play in relation to suicide across Cheshire and Merseyside. And because we've already covered some of those data, we won't repeat elements of that in this presentation. And I should say at the outset, just a few thank yous. Firstly, to Champs for their particular support of this area of work over the course of what was really been the last 2 years, given the impacts of COVID, which we'll come on to. And particular thanks go to Neil and Lucia for the support that they've given us, and the other project leads and contributors whose insight hopefully we're able to capture today and to share learning across the network and among colleagues who are joining us on this important day in the annual calendar. And today we do very much want to focus on some of the key practical lessons that have been learned from the various projects that we've had the pleasure of supporting and working with to evidence over the course of the next 18 months. So next slide, please, Tracy. The outline of today's session really is threefold. Firstly, as I mentioned, we want to share some of the learning from the National Health England first set of funding for the suicide prevention project, which were delivered between February 2020 and June 2021, and the focus was on middle-aged men, broadly defined as 40 to 60-year-old living across Cheshire and Merseyside. The purpose of the funding and the projects more widely was to prevent suicide among middle-aged men and to improve their mental health and overall well-being. And 8 of the 9 local authorities across the region took part in the work that we're going to share with you today. As you'll see, quite a number of those, understandably, were affected in different ways by the pandemic, but there was lots of innovation and support given to people throughout the region that we'll come on to. On the next slide, what we just briefly summarise, if we can, Tracy, is just to capture some of the projects which were delivered across the region in that period. In total, 27 suicide prevention programmes for men were delivered in Cheshire and Merseyside. And that they're very diverse. Some focused on sport, others on cultural activities, others were held virtually, others were in person when restrictions were lifted, as we'll come on to see. Others focused on mental health training, suicide prevention and intervention work. Others focused on more IACT-related activities or counselling. So it's real diverse set of programmes which were delivered within each of the areas and across the region more widely. And I think this really does pay testimony, I think, to the innovation and the willingness of people across the region to identify creative and effective ways of engaging with men who are at risk of suicide and who have engaged in suicidal behaviour throughout the last 18 months. Next slide, please, Tracy. Those programmes can be broadly defined in a number of ways. Some of the programmes which were delivered were very open-oriented programmes where any group of men who fitted into the key age criterion earlier were able to participate. Other programmes targeted particular populations such as veterans or particular types of conditions, some men with pre-existing diagnosed mental illness. So there's a real rich variety of those, and some of those were delivered as one-off events, such as time to change events. Others were delivered as weekly programmes, and we'll come on to, some of those were delivered wholly online, some in person, and in other cases there was a blend of both online and in-person delivery. There were various activities, as I referred to earlier, and I think there was no one single set of activities which had a demonstrable impact at a level which is better than the others. The diversity and complexity of the conditions and delivery mechanisms that characterise a programme is really important. And what we've tried to identify during the course of the presentation today, and there will be an accompanying report which will be published shortly, which captures this learning, and that will be circulated among colleagues in the network and beyond, where we begin to flesh out some of the detail that I'm going to share with you and Michael this morning. So next slide, please, Tracy, thank you. Just to give you a very brief overview as to how we undertook the evaluation. Unfortunately, of course, because of the impacts of the pandemic, we had to do all of the activities in a virtual environment. Our preference would have been, of course, to have worked with projects and colleagues on the ground in person, but like everybody, we had to amend the delivery mechanisms. What we have essentially done since November 2020 is to hold a series of stakeholder engagement workshops with colleagues throughout Cheshire and Merseyside. And in the first instance, we did those within each of the local authorities. And then as time progressed throughout the evaluation, we then brought together colleagues from across the region into cluster workshops, where we were able to share some of the learning that we're going to explore today, but also to really reflect upon some of the real-time surveillance data and challenges that colleagues who were on the front line were clearly experiencing, and how we use that opportunity to identify practical actions which could be used to help support men who were in distress, to help prevent suicide and to help shape continued delivery. That also included, which was really important for us, expert by experience workshops, and colleagues throughout all of the regions were invited to take part throughout in a series of co-produced workshops, where we were able to reflect on lessons learned and to ensure that what we are able to produce as part of the report can be actionable and is practical, and can kind of shed light on the things that seem to go well over the course of the last 18 months and some of the challenges that we continue to face. And it's clear, I think, from the data that we've presented earlier that we must keep going with and reflecting upon the learning that we can take from the community-based, place-based approaches to suicide prevention, which essentially underpins much of what we're talking about today. So what we want to do is very quickly run through 4 key themes or areas, if you like, that hopefully will be of interest for colleagues who are working throughout the region. So if we can just move on to the next slide, Tracy, the first key learning area is very much programme design and engagement methods. And as you can see, we have 3 others that I'll come on to. So for each of these, what we've decided to do is just to summarise some of the top lines of the learning that we've taken from colleagues from the programmes that have been operated throughout the course of that period. And then we've tried to identify some of the key quotes or case studies that have been shared with us in each of those kind of consultation exercises in the hope that that will benefit others working in this space. So if you just move on to the next slide, please, Tracy. What we have here are some of the top 6 key points, if you like, related to programme design and engagement. Not surprisingly, and this is the core strength of programmes which exist throughout the region, there was a very important emphasis placed on incorporating lived experience and men with lived experience, people who have experience of mental illness, people who have engaged in suicidal acts or have had suicidal ideation, but also who have experience of supporting those who engage in suicidal behaviour. That was really important for the men who engaged in many of the programmes that were delivered, because it was seen particularly as a non-stigmatising opportunity to engage and recruit new men to programmes. And those programmes are really important, both in terms of the marketing, but also in terms of the activities which were provided, when they were provided in plain, everyday language to which men could relate from a whole range of settings. Many of those settings were non-clinical environments. They included local community assets. In some of those instances, it related to professional sports environments, and others it was local community centres. Some of the local publicly accessible spaces in Liverpool, for example, included the docks and others where men could go even within some of the restrictions that were imposed early on in the pandemic. And those non-clinical environments, as we know, were really important in attracting men who otherwise wouldn't have engaged in mental health or suicide prevention activities which were provided in clinical settings. And Tracy, if you'd like to just share the other 3 quotes that are on there, so colleagues can perhaps reflect on those as I'm going through the remaining 3. That peer support in non-clinical environments was absolutely critical for many of the men who colleagues were supporting throughout what was very clearly a very distressing time. And those protective factors, peer support, non-clinical environments and the everyday language was really important in retaining men in the particular types of programmes for which they were seeking support, whether that was individually or from other groups of men whom they already knew. What was particularly important also in some instances was incorporating the experience and lives of partners, families and friends from men. We often hear of the nagging factor or the encouragement that was given to men from their female or other male partners to go and seek support for their mental health and to actually get involved in some of the programmes which were being delivered in their local area. And that was really important, particularly where men were especially reluctant to engage in clinical support. So the community-focused interventions and programmes that were supported by this fund was really important in supporting some of the most vulnerable men who perhaps would have engaged in other forms of suicidal behaviour had those programmes not been there in existence. Also important was enabling men, once they joined the programme, to identify the programmes and activities in which they would find the greatest benefit and support. And as I recalled earlier, there were lots of diverse activities. And what was really important was they were driven by the interests of men. Some included, for example, music, football, or the cultural and arts activities. Others included more counselling and clinical activities alongside more community-based programmes. And what was really important was that enabling men to identify what was most relevant for them, enabled men not just to seek support in the immediate instance, but actually to ensure that men could be supported throughout the course of their time, either on the programme or in particular events. So they were some of the key ingredients in terms of the initial design and engagement. And if we move on to the next slide, please, Tracy, on to delivery methods. There were a number of key issues also that colleagues reported to us as being particularly effective, or some of the changes and challenges that needed to be made to increase the engagement and support given to men as part of this. So if we can move on to the next slide, Tracy, please. Those 5 key issues included, as I'm sure colleagues will be familiar with, digital poverty. In a number of instances, some of the challenges that colleagues encountered was the lack of access and knowledge and awareness and ability to use digital support, which was provided during the early stages of the lockdown. And clearly we need to give significant support to those members of our communities who are not able to access technology, whether for the purposes of mental health or suicide prevention, or indeed for other areas of life. And again, Tracy, if you could share some of those quotes while I talk through the remaining points, that would be appreciated. Because I think some of these quotes do help to bring to life some of the challenges that the colleagues working on the front line face, particularly those men who were living in supported accommodation, where there wasn't communal access necessarily to broadband or to Wi-Fi, and particularly men who are in recovery from substance misuse in particular, who didn't necessarily have the ability to access some of the various technologies that we were all encouraged and required to use to support men online throughout this period. So for some men, they remain particularly vulnerable and at risk where they were unable or unwilling to access the various technologies that were available. Other challenges in terms of the practical delivery of programmes also related to transportation, particularly where programmes were delivered in sites which were deliberately or originally designed to enable men to attend, for example, through local train lines, or indeed through local bus routes, where there were significant restrictions to those, or where they were being used quite heavily because the services were reduced. That did present a challenge for some of the vulnerable groups of men who didn't have access, for example, to cars or other methods of their own transport to access programmes. So programmes did work creatively to begin to overlook those, but I think going forward, that some of the lessons there for us to reflect upon include how we can ensure that programmes remain accessible to people who experience transportation challenges alongside the technological challenges. And without question, as we move into the next phase of recovery from the pandemic, we need to consider some of those major challenges. Others also reflected upon some of the concerns for some men. One of the reasons why they didn't engage in online activity, such as what we're doing now, is actually concerns around trust and who would potentially be listening to the disclosures which they made online to councillors or to other community programme providers. And again, that's another challenge for us that we need to reflect upon, about how to engage those men who wish to disclose or seek support, but don't wish to do so in online formats. Other men who were in employment have reported that they were much less willing to engage in online out of work support activities, because essentially, like many of us, I guess, they experienced a lot of cognitive burnout for spending so much time online when they were working. In one instance, for one programme which provided mental health first aid and other forms of training, they actually noticed almost the opposite to this, insofar as that it enabled them to reach a more diverse group of men and to reach a wider number of men, because it was accessible, and it was because the training could be provided at times that were more convenient for men, and indeed for those providers, it also helped provide better value for money. So there isn't necessarily a one-size-fits-all here, and it is the nuance and the complexity in the detail that certainly going forward we need to reflect upon as programme providers, particularly in local communities, and how we interface with clinical services as the integrated services and care systems come on stream in advance of March next year. So if we move on to the next slide, please, Tracy, and you may just flick on to the next one as well, please, which is really the COVID-specific learning that colleagues reported to us as a consequence of the delivery that they had provided during this period. It was really notable among the programmes that supporting the personal well-being of colleagues who were delivering programmes, whether in a paid capacity or as volunteers, was a real learning point for many of the programmes. And again, Tracy, if you could share those 3 quotes on the screen, colleagues can reflect upon that from their own perspective. And I think this was a really honest reflection for many of us that were involved in the programmes, that we almost potentially take for granted the support, willingness and work that many of us do to prevent suicide and support mental health across the region. But we don't necessarily always reflect on the need to support the staff, and many of whom are volunteers who do that. So many of those colleagues are keen to ensure that that continues going forward, so that we can continue to support the workload of those colleagues who support many people, many of whom are in distress, not just men, of course, but people of all ages, genders and backgrounds. And that's particularly important. Much of that labour went unfunded because of the workload imposed by COVID and the restrictions imposed during the national lockdowns. And in other instances, the ways that some programmes try to respond to those challenges was, of course, through social media and other online activity. And where men were able to access those opportunities, it was shown to have helped men continue to interact not only with programme providers but with other programme participants. And it was key, clearly, to reducing isolation and loneliness among those groups of men who were able to access these types of services. But of course, as I said earlier, not everyone could do that. So we certainly need to see this as one among many other types of strategies, including in-person strategies, that we need to use in our community programmes to help support mental health and prevent suicide more generally. For some of our colleagues who are working, it was clear that hybrid ways of working in the future will be retained where it's possible to do so, and when it's beneficial and provided in the right circumstances and for the right reasons for men. And I'm sure many of us on the call here are already beginning to think and act in these ways about how do we adapt some of the delivery, but crucially, how do we do so in ways that do not leave some of the most vulnerable groups of people in our local communities and society, and ensure that they do remain involved in ways of delivery that can be maximised in an in-person capacity, and that men aren't left behind, if you like, when those services are supported or can't operate in person. And notably, what was also key for many of our colleagues was that throughout the periods of lockdown, particularly in the early parts of the pandemic, the local relationships established with law enforcement, particularly the police, was important, because the police could be one of those groups who could reach out to people who were at risk of distress or who were experiencing various challenges that were of concern for programme staff. So colleagues were particularly keen to emphasise the role that those colleagues played in really becoming part of our local protective factors delivered in communities, rather than necessarily just being a response service, as is often the case in this particular area. The final 2 slides from me, please, Tracy, really reflect on that particular network to which I've just referred. The unintended consequence of having to move all of this online, and not just the learning and insight, but actually working with colleagues to deliver suicide prevention and mental health support online, was actually the creation of new local networks within regions, but also across the region, which enabled us to share intelligence, insight and knowledge in ways that could really benefited service users and other people who were delivering programmes in real time. So we didn't need to wait 18 months or 6 months for a report to be published to share learning. And I think this is one of the key benefits and areas for sustainable activity and working that we wish to support, not just at the university and at Everton, but actually among colleagues who are really interested in supporting this area of work as a consequence of the evaluation. So if we can just move on, Tracy, to the next slide for myself, and then I'll hand over to Mike. This type of network, not just the programmes who were involved in the evaluation, but their partners as well, identified opportunities to meet regularly, monthly or quarterly, to really share best practice and reflect, for example, on things like participant recruitment and what was working in some areas and how that might be shared across other areas of the network. There was much enthusiasm, not only around that, but also about how we could share resource. For example, the Stay Alive app, the Suicide ZSA training in particular was disseminated among the network. What was also particularly key was we saw integration of sectors and colleagues working across diverse sectors who had never worked before together, but who've begun to identify emerging priorities and challenges. And one of those key ones that we identified across the sector through the work with men is also the growth in concerns around self-harm and suicide prevention among young women, but also older women as well. And what was also particularly seen as important was how we signpost lots of local colleagues and service users into local community-based programmes. And we're delighted that the No More Suicide website has begun to capture some of this learning and will in the future act as one of those signposting methods of activity where we can share not only the experience that we've got here, but also details of the programmes in which men can be engaged more locally and more generally. So what I'll do now, I'll hand over to Mike, who will talk about one particular initiative that we're trying to do and engage in here to ensure that the sustainable networks that we've developed and that colleagues wish to engage in and to really kind of look at some forward-facing activity across the region.
Thanks very much, Andy. And for the final part of the presentation, I'll quickly talk you through some of the work at Everton in the community in general, and also move on to our most recent capital project, the People's Place, which is very much aligned to this year's theme of creating hope through action. So as you can see here on the slide, the current work at Everton in the community, which involves delivering over 60 different projects supporting various population groups, helping to address various social needs. It's been shown to demonstrate that for every £1 invested, you can generate £14.74. And building on this work, as we can see on the next slide, we now want to develop our most recent capital project, which is called the People's Place. It'll be essentially a mental health hub, a space where people can come along and engage in various evidence-based activities. And on the next slide, we can just see that it will be the first of its kind aligned to a Premier League football club, which will help to generate a lot of attention, a lot of focus to this, which will help to raise awareness of mental health in general, help to normalise conversations around mental health, tackle the stigma surrounding mental health and mental illness, and importantly, as I've mentioned, provide a space for that evidence-based activity to take place where we can help to promote good mental health and help to promote suicide prevention. It will be an overarching service available to as many people as possible. I do want to stress it's not only for Evertonians, it's open to any people, regardless of football allegiance, age, gender, location. And as you can see here on a couple of images, we've tried to create an attractive, appealing facility, and also a place where it's very flexible, so we can take we can offer a range of different activities within that space. And this will be located just across the road from the current Goodison Park Stadium, which literally a 2-minute walk as part of the whole Goodison campus. And on the next slide, this just shows the different activities that will be delivered within the facility. So 4 main areas: sport, physical activity. We'll have a range of these activities taking place. Also signposting and awareness, linking in with chasing the stigma and the hub of hope. education and development, and also community engagement. In terms of community engagement, we want to make sure we can also offer some activities which are completely non-stigmatized to help get people inside the building, and once they're inside they can then access the various activities available to help improve their mental health, to help normalize that conversation around mental health, and also to support with the wider suicide prevention agenda. And what we try to do here is look at all the various risk factors for suicide, whether that be social isolation, income instability, job insecurity, all those different risk factors which we know have been amplified over the last 18 months or so, and build them into this one space here. And as Andy's touched upon, that network is very important to ourselves, because what we can do here is provide a whole range of activities internal to ourselves, but also we know there's so much more out there externally as well. And we also know that we're not everything for everyone. So yes, we can provide a lot of activity. We currently deliver 15 mental health specific projects across the entire life course, supporting from conception with our New Dads project right the way up to supporting older adults. Our oldest participant is currently 104 years of age, so it's a very extensive continuum. But yes, across that life course model, we do offer support for antenatal, postnatal children and young people, middle-aged men, middle-aged ladies, military veterans, as I say, various population groups with various social needs. We link in a lot with the local primary care network to make sure that GPs can refer onto ourselves. And in addition to the activities we can provide here, we also have our own GP, Dr. Chris Pritchard, who is on site with ourselves. We have a trainee GP as well. So it's also providing a real kind of a layer of medical support, but importantly within a community setting to make sure that men feel comfortable to engage. And on the next slide, please, Tracy. We can see here, in terms of making it comfortable to engage, we've wanted to create a very luxury setting where it will be appealing, it will be a space where people feel comfortable to talk about anything it may be, and as they develop relationships, they can then talk about mental health and how they are going along their journey. But again, this is absolutely open to anyone. And on the final couple of slides, yes, just the last slide here, again, just from a street view. If you just go back one, yeah, this was previously derelict land, a hotspot for antisocial behaviour. And again, the intention is to secure enough funding to make this a reality. So we're just at the stage now where we're building the foundations, and around this time next year, we're hoping to then have this open. And obviously this will then create that hope through action. This is the action that's taking place, which for people who may be in a difficult position, it's another option. And I think collectively today is a fantastic occasion to bring together a number of partners and stakeholders where we can discuss all those different options that we can provide to make that menu as comprehensible as possible, so that when people are feeling in a difficult moment, they have plenty of options to get involved with. And I'll end here, but we're going to take on some questions shortly. So I'll hand back to the chair, and then we'll take over from there. But thank you very much for the invitation to be involved today.
Thanks, guys. Absolutely fantastic presentation there from you both, and we've prompted quite a lot of activity on the chat. There is a couple of questions, people asking for resources, etc. I suppose if the speakers can get back to them in the chat, but we can take a couple of questions. So first from Councillor Kate Cernick has asked, did the research look at the most effective ways to disseminate information about activities and events, social media and local press? I think that was asked when you were doing your bit, Andy, so perhaps you might want to come and answer that.
Yes, thanks, Councillor Burns. Yeah, the colleagues reported a number of effective ways, really, in which they engage men. Some of those were word of mouth through the local community networks that were already established, and that was very clearly important in engaging men who weren't, for example, able to access things like the social media activities or some of the more printed materials that were disseminated among other services. So word of mouth was certainly important. Some of the digital remote activities through social media were also key, as I've referred to. But the pre-existing relationships between the providers of programmes and also the men who were already engaged in some of the local support networks was also key in recruitment. And whether that was recruitment that was done in person, in and through the local community assets, did vary depending on the types of programmes that were in existence across the particular regions. So in some cases they were quite traditional, in others they were more innovative through online activity. But in other cases it was also to do with capturing some of the vulnerable groups of men who are already engaged in other types of programmes, which were delivered by services or by the community organisations which were already delivering in that space. So it's a lot of local intelligence sharing, and I think some of that real-time practices, those real-time practices that I referred to really helped in that.
Thanks very much for that, Andy. I hope that answers your question, Councillor Sir Nick. And then we are just on to the break time, but I think there's another question in here which it'd be good to take, and it's from Kate Mooney, and she asks, how were the men successfully engaged with the services? And also, are the services sustainable? Are they still available, or what happens to the men accessing them when they stop? So maybe we can just cover that before we get the break, if that's okay.
Yeah, of course. I think some of those key engagement methods were through some of the recruitment challenges that I've just discussed. I think in terms of retained engagement, it did very much depend on some of the activities which were being provided, whether they were done in a virtual space or whether they were done in person. Some of the colleagues reported doing lots of hard work by engaging with men one-to-one, whether that's through phone calls sometimes, through email, through online chats, through counselling or IAPT-related activities which were done virtually, and that was important also to ensure that men continue to remain engaged. In terms of sustainability, that's a really important consideration. I guess that's one of the reasons why we're very keen, as Mike just referred to ensure that there's some activity that could be delivered across the region through the People's Place and elsewhere, but more locally in those local communities. Some programmes are ongoing and continue to be provided by the relevant organisations. They will also be captured on the No More Suicide website, and so you will be able to access those programmes and the details there to refer men to. In other instances, where there were more one-off related events or activities, the challenge now is to ensure that some of those local programmes do remain sustainable, whether that's through the pooling of resources between organisations, whether it's through new funding through the network or elsewhere. That's one of the major challenges. But what was really key is that many of the programmes were delivered by pre-established communities and pre-established organisations in those communities, where we are able to retain contact with men. But of course, that in and of itself needs further additional support, particularly as the kind of next set of challenges when the pandemic really become known.
Thanks very much, Andy, and I'm sorry to rush you. I wish we had more time because it's been quite engaging, but thanks very much for your piece there. Right, we're a few minutes late. I feel like I'm presenting on TV now, so after the break, we will have the fantastic Professor Rory O'Connor, who will take us through his presentation. So get your questions ready, go and grab yourself a brew, and we'll see you at about 3 minutes past 11. Thank you. Okay, welcome back, everybody. I hope you had a chance to have a nice cup of tea, cup of coffee, a nice break, ready for our keynote speaker. And you'll notice we're delighted now to be joined by Professor Rory O'Connor. Who I said before, he's a professor of health psychology, Suicidal Behaviour Research Laboratory at the Institute of Health and Wellbeing from the University of Glasgow. And he will present on his latest book, When It Is Darkest, Why People Die by Suicide and What We Can Do to Prevent It. Just like to encourage you all to please engage with this session. Any comments or questions in the chat for Rory, that would be great. Delighted to have you with us, Rory. Over to you.
Thank you so much, Councillor Burns. I'm absolutely delighted to be here today, and sadly I can only join for my session because I've numerous commitments because of World Suicide Prevention Day and my role as President of the International Association for Suicide Prevention. But it's absolutely fantastic seeing so many people here, and then Helen and Tracy I've been dealing with. Sincere thanks to all the work they've been doing behind the scenes and the amazing work going on. It's really fantastic and encouraging to see. So yeah, what I'm going to talk about is the research that we've been doing, but in the context really it's framed in terms of my book, When It's Darkest, which I published. It came out in May of this year. And so When It's Darkest was my attempt to try and bring together the 25 years that I have been working in the field. But I was really conscious of the fact that although we've made huge progress in the last 10 or 15 years in particular in challenging the stigma around suicide and helping people better understand its complexity, that I felt that we'd still a long way to go, and that when I was writing the book, I was keen to write a book which was accessible to anybody and everyone, but in particular to people who were being directly affected by suicide, those who had either lost loved ones to suicide, had been suicidal themselves or attempted suicide, or people who were supporting people with suicidal thoughts and behaviours. And so what I've tried to do then is bring together sort of my personal reflections, my personal experiences with my professional past experience and knowledge. As you can see in the book tries to cover the whole spectrum of understanding and preventing suicide. So it starts in part 1 with an overview, then we're moving into challenging myths and misunderstandings, and I'll touch on those today. And then really in part 2, we're trying to make sense or understand what it feels like to be suicidal. And I do that then in the context of my model of suicide. And then in part 3, I try and touch on what the advances we've made in recent years in terms of psychological and psychosocial treatments and interventions to protect the vulnerable. And I'll say a bit about that towards the end of my talk. I'm planning to talk for about 30 to 35 minutes, and then hopefully 5 or 10 minutes for questions. And then part 4 of the book is really one of the messages we've been doing, coming out with in terms of the world context of suicide prevention and the International Association for Suicide Prevention. And we've been asking people to reach out, and we've been asking us to ask people whether they're suicidal. If you're concerned about somebody, please ask them. And so in part 4, I try and provide some guidance and support on how we might do that, ask those difficult questions, as well as how we can support friends, colleagues, and family members who are suicidal. And then lastly, really to challenge, or to help us understand the bereavement of what it feels like to deal with the aftermath of a suicide. So as I say, that's what the book we're trying to do. I've been trying to do in the book. And in terms of the summary of it, then really it is this combination of personal and professional. And I've tried to tell something of my own story. I've been twice bereaved by suicide, and I try and talk about the impact of that on my experiences of working in the field of suicide research and prevention, and how I didn't know, after my close friend died by suicide, Claire, who I talk a lot about in the book, when she died by suicide in 2008, I just didn't know whether I would be able to continue in the field, because every single day I'm dealing with suicide, and I find that really challenging. But also in terms of this journey my journey in suicide research and prevention, I'm also drawing on the many people I've met along my journey. So people who've been directly affected by suicide, those who have been bereaved, as well as those who have attempted suicide. And I've learned so much from the generosity of those who've taken part in our research, or those people who have contacted me directly. And so that's what I try to do in the sort of narrative of the book, is bring to life is one way to describe it, but maybe illustrate what I'm trying to say in terms of understanding and preventing suicide in the context of people's stories, including my own. So that sort of overview, I'm going to then move in now very quickly to the scale of the challenge we face. I'll say a bit about COVID-19, and then I'll touch on a couple of the myths around suicide, which are covered in detail in the suicide. And then I'll really get into the nuts and bolts of my model of suicide, but then this key challenge I think we all face, all of us working in suicide prevention, is understanding what is different about people who have suicidal thoughts but don't act on those thoughts, compared to those who make that transition from thinking to attempting suicide, or sadly dying by suicide. Much of the work I'll talk about is conducted within my research lab at the University of Glasgow, and it really is a team endeavour, and a lot of the work I'll reflect on is work which has been led by others in my team. And I'm really grateful for the support of a whole range of organisations listed here, but including people who've been directly bereaved by suicide, who've then generously donated to our research lab to support the work that we do. So if we then think about the scale of suicide, and it's so important we think about this on World Suicide Prevention Day. So the latest data suggests that at the very least, 703,000 people lose or struggle to live globally each year. And that's most likely an underestimate. But then if we think of the wider ripples of suicide, Julie Carell in the United States has estimated that for every person who dies by suicide, there's 135 people potentially affected, potentially bereaved. Now, obviously not all of them will need support directly, but some of them will. So if you do, excuse me, if we do the maths on that, in terms of the impact, so if 135 people directly affected, that gives us about 95 million people potentially adversely impacted by the death of somebody. So the scale really is vast. And indeed, another way to frame it is globally, every 40 seconds, somebody dies by suicide and another 20 will attempt suicide. And again, that estimate of suicide attempt is likely to be an underestimate. And as we're all well aware at this meeting today, 3/4 of all suicides in the UK are by men. And in some age groups, suicide is the leading cause of death. So it really highlights the scale of the challenge that we face and the fact that when we talk about levelling up and ensuring that mental health and physical health are equal or seen as equal, they're not, and we need to do more, much more in ensuring that we get the resources put into mental health and put into suicide prevention itself. But then in terms of the world we are now living in and the pandemic, at the start of COVID-19, a group of us were really concerned that the mental health wasn't going to get the same focus that physical health had got at the start of COVID-19. And that's understandable because obviously the physical effects of the virus were killing people and we needed to act quickly, and we did. But we were really keen to really ensure that we did enough to put safety nets and mitigations in terms of mental health, because our concern was that the suicide rates may increase in the time of COVID. And what we've been trying to do is monitor the sort of impact of COVID-19 on both suicide, and you'll see in a second, on other indicators of suicidal behaviour. Now, this slide here illustrates the most comprehensive study to date conducted looking at the impact of COVID-19 on suicides globally. It's data from 21 countries. The study, there's over 70 of us involved in it, but it was led by Jane Perkis in Melbourne and Anne John in Swansea. But these data look at the impact of COVID-19 up until the end of July 2020. So it's the early impact. Now, the reassuring news is that looking at these data from those 21 countries, this study did not include England or the UK, but I'll come back to England in a second. But the data were broadly reassuring. There was no evidence of an increase in suicides in that early phase of the pandemic. And then most recently, as you may have seen last week, the ONS data were published, and there's no evidence of suicide rates increasing thus far in England either. And that's the same across the UK. But we need to be vigilant. And one of our key messages is that although the data are really encouraging, they're only the data from the early part of the pandemic. And our concern is that the issue is that when furlough, as this month furlough ends in the UK and other safety nets are removed, people who are particularly vulnerable are at increased risk. And there are also some data from Japan from later in 2020, which show that there was an increase in suicides after an initial decline. So encouraging that we haven't seen the increase thus far, but we need to remain vigilant. And indeed, that vigilance is borne out by some work we've been doing at the University of Glasgow. Again, around the same time at the start of the pandemic in March 2020, I was fortunate enough to bring a group of people together and secure funding from a range of organisations listed here, so we could try and track the mental health and well-being of the UK population. And we were able to recruit a sample of 3,000 adults, broadly representative across the UK, and track their symptoms of depression, their symptoms of anxiety and suicidal thoughts, and a whole range of indicators. So I'm just going to hone in on some of the findings we had from the first 6 weeks of the pandemic. So if we all think back to those first 6 weeks when we had huge uncertainty, and that's waves 1, 2, and 3. We went back to people 3 times across those first 6 weeks to look at the immediate impact of people's mental health and well-being. And an interesting pattern emerged. Excuse me. First of all, if we just look at, we've got here symptoms of anxiety and symptoms of depression. Now, these are using standard measures, and we're using these standard cutoffs for these scales. So above 10 in both of these measures indicates symptoms which are potentially indicative of moderate or severe levels of anxiety or moderate or severe levels of depression. So what we can see, and if we look at the left hand first, in the levels of anxiety, we can see markedly high levels at the start of the pandemic. 21% of the adult population were reporting these high levels of symptoms of anxiety. But we can see there's a recovery. People recover and adjust over those 6 weeks. Now, those levels are still much higher than you would expect. So in non-pandemic times, you would expect about 5% of the population to be reporting above these levels. And then if we look at levels of depressive symptoms, again, really high, about a quarter of the adult population at wave 1. And there's a slight decrease, but it's not statistical. So the statistical reduction. So the conclusion from the first 6 weeks was initial spike in symptoms of anxiety, but there's recovery, and levels of depressive symptoms are relatively stable. And it's also important to highlight that I can't say anything about the impact of people's mental health and well-being before the pandemic, because this sample were recorded after it, were recruited after the pandemic started. Now, then when we move on to look at suicidal thoughts, we see a worrying trend, which gives me cause for pause and caution. So what we can see is over the 6 weeks of the pandemic, suicidal thoughts seem to be on the increase. Now, you think about that, that's against a backdrop of symptoms of anxiety decreasing. Now, when we try to understand why that might be, we think because when you're trying to assess depression and anxiety, we ask people usually to reflect on how they felt in the previous 2 weeks. So it's an indication of past thoughts and feelings and behaviors. Whereas for you to make a decision about whether you're suicidal, you have to project yourself into the future. And I think that early phase of the pandemic, I think that uncertainty, that fear and uncertainty really was contributing to people's suicidal thoughts. So that was concerning. But what's even more concerning is when you do some fine-grained analysis by age group, for example, what we can see, and it's been reported widely across a whole range of studies now, is that the young people, in this case, the green line on the left-hand figure, young people's mental health is most adversely affected compared to the other age groups. And if we look at gender, although there looks like women reporting higher levels of suicidal thoughts, it's not a significant increase. And indeed, if we then look at across other groupings, so people from more socially disadvantaged backgrounds, are more reporting significantly higher levels of suicidal thoughts. But even more stark is if we compare people with and without pre-existing mental health problems before the pandemic. So we just look at wave 3 here. We look at wave 3 in the orange line, representing people who had pre-existing mental health problems. 20% of them were reporting suicidal thoughts, compared to only 6% of people without pre-existing mental health problems. And indeed, I haven't got the data here today, but we've continued to track the sample up until March of this year, including the last lockdown. And what we see is this consistent pattern of particular groups of people reporting significantly higher levels of mental distress. So young people, with pre-existing mental health problems, and those from more socially disadvantaged backgrounds. And that still holds as we track people across the piece. So although the data broadly from internationally with regard to suicide has not shown an increase yet, and the most recent data from England showed a decrease in some groups across the piece, but in some groups in particular, we have yet to see, thankfully, an increase in suicide. We need to be vigilant because recovery will be bumpy. Okay, so that's just to give you context of the scale and some of the current issues with regard to the pandemic. So if we look then at the complexity of trying to understand suicidal risk, this figure, it just really is to illustrate, and I'm not going into detail about it, it's just to illustrate that when we're trying to understand suicide, we have to understand that the causes are biological, social, clinical, as well as psychological. And indeed, we need to always take a lifespan perspective, and recognizing that somebody's suicide risk in adulthood will be influenced by their suicide risk or what's happened to them in the past. So under these distal factors here, you can see early life adversity. We know that early life trauma and adversity are associated with suicidal risk. So it's important that we do that. But what I want to focus in, and the remainder of the talk will really try to focus in on what the sort of more proximal factors, and trying to understand the fact that suicide is usually caused by feelings of defeat and humiliation from which you cannot escape. And it's this sense of entrapment, which is mentioned here in this box under proximal factors. We're trying to understand what leads people to feel trapped, because that sense of entrapment, as you'll see in a couple of slides time, is a key driver, in my view, to suicidal risk. But before I go into the details of entrapment, I want to just say a couple of words about the myths, which I highlighted at the start. So what struck me when I was writing my book was I was reflecting on what has changed in terms of our attitudes and understandings around suicide. And I reflected on a talk I gave in the mid-1990s in Belfast, which coincidentally, I'm sitting in a hotel in Belfast today after giving my first in-person talk in 18 months yesterday, which was a remarkable experience, seeing people not on Teams or on Zoom. But what was remarkable, this list of 14 myths included here are from a slide from a presentation I gave in the mid-1990s in Belfast. And the stark reality is these myths still persist. Now, what I'm just going to highlight, and there's more details, it's all described in the book. I'm just going to highlight one myth, which is really important in the context of today, World Suicide Prevention Day, and the work that we are all engaged in trying to prevent suicide. So in that, on number 4 there, asking about suicide plants the idea in someone's head. Now that's an absolute myth. There's no evidence at all that asking somebody whether they're suicidal will make that person suicidal or plant the idea in their head. However, there is evidence of the opposite, of the contrary. There is evidence that if you ask somebody directly whether they're thinking of suicide, it could be the start of a life-saving conversation, but crucially, there's evidence that if you ask that question, people are more likely then to get help, get support. So I suppose my message is, when we're thinking more broadly in public health domain, when we're talking about suicide, we need to dispel these myths, and that's just one example. And again, much more detail in the book, those of you who want to know more about the myths. Okay, so I want to then come back to this sense of entrapment. And this sense of entrapment is at the core of my model of suicide. So this IMV model. Now this model looks more complicated than what it is. And what I want to just focus on are really the middle bits. So the motivational phase and the volitional phase. And so I've highlighted this already, this idea that if you're trying to understand why somebody becomes suicidal, although there are many different factors in terms of clinical factors and biological factors and social factors, what you're trying to understand is how those factors impact on an individual to make them feel either defeated or humiliated. And that could also be linked to shame or to rejection or loss. And crucially, that sense of defeat and humiliation, if you cannot escape those feelings, that sense of mental pain, that entrapment, is a key driver for suicidal thoughts to emerge. And so when we're trying to understand suicidal risk, we're trying to understand what are the factors that lead somebody to feel defeated and humiliated and that they feel trapped by. And then the second key bit about the model is, so the motivational phase is all to do with the emergence of suicidal thoughts. And then the other bit is the volitional phase. And the volitional phase is helping us to understand this transition from thinking about suicide to acting on your thoughts of suicide. And I'm going to return to that in a couple of slides time, because there are 8 key factors that I think are important in helping us understand who is more likely to act on their thoughts of suicide. So, and again, this is described in the book in detail, and if you go to our website, suicideresearch.info, there's lots of examples of me talking about the model to help you better understand it. Now, I've made a big song and dance about the importance of entrapment, and we've done lots of studies on this. And this is just one example of a recent study in which we try to see, could we predict people's suicidal thoughts over time in a young adult sample? And all I want you to take from this statistical slide is 2 messages. One is internal entrapment, this internal mental pain, is a key driver to how suicidal people think over time in this sample of a non-clinical sample. And people feeling a burden on others. That sense of feeling a burden on others often contributes to that sense of entrapment. And that combination then increases risk. But the key driver is understanding the emergence of entrapment. What is it that's leading to that sense of pain, that being trapped by mental pain, which you feel shame or a burden or disconnected? And indeed, then the obvious next question is, well, how do we measure it? How do we record or assess entrapment? What do I mean by it? Now, we use the widely used scale developed by Paul Gilbert and Steve Allen in the 1990s. There's 16 questions about entrapment. Now, that's far too long if you're trying to use in a clinical context or even in research purposes. So with the colleagues in the Netherlands, we developed a briefer version of it. So we've identified 4 questions from the original scale, which do as good a job as assessing entrapment as the full 16 questions are. And here are the 4 questions. 4 questions are relatively straightforward, but they're really, as you can see here, just asking directly, how trapped do you feel? Do you feel trapped inside yourself? That's an index of the internal entrapment. So it's important that when we're thinking about understanding suicide risk in any one of us, but if you're a clinician working in the front line, I think you should be routinely assessing entrapment, and entrapment should be a treatment target. But then if we're thinking more broadly in a public health or in any context of suicide prevention, ask ourselves the question, is our society contributing to making people feel trapped, contributing to making people feel defeated and humiliated? And what can we do to alleviate that? Okay, so that's all I'm going to say about entrapment. I want to now say, basically, we're now living in a time of COVID, and I got slightly distracted. A message came in there. It's always a challenge of trying to, I can't multitask clearly. In time of COVID, one of the concerns we've had, and in the UK, obviously, there's now a huge policy focus on dealing with loneliness. And we've looked at this more recently in the context of suicide, prevention. And this is, again, don't worry about the statistics in this, but this is led by my colleague Heather McClelland. We reviewed all the longitudinal studies to see what does loneliness actually predict suicidal behaviour over time. And we looked at the worldwide evidence, and you can see there's a relatively small number of studies listed in this figure here. But basically, the evidence is clear that loneliness certainly predicts suicidal behaviour and suicidal thoughts over time. And crucially, it seems to have an impact via making people feel depressed. So loneliness leads to depression, and depression then is associated with suicidal risk. But we've also looked at this in the context of my model, the IMV model. And again, I'll just point you to the key message here. The key message is in this right-hand figure, this right-hand graph. And again, we've just looked at, if you look at the dotted line and at the very top, the highest point of the graph. The highest point of the graph represents people who reported high levels of loneliness and high levels of entrapment. So it seems there's a synergistic relationship such that high levels of loneliness plus high levels of entrapment are associated with increased suicidal thoughts. So what it highlights is the importance at a policy level, at a community level, and an individual level that we tackle loneliness. And indeed, on World Suicide Prevention Day, with our message of creating hope through action, anything any one of us can do which alleviates a sense of loneliness, which promotes a sense of connection and belongingness, will reduce suicidal risk. Okay, so that's all I'm going to say about the sort of the emergence of suicidal thinking. In the sort of last part of the talk, I'm really going to focus in on this transition. So this crossing the precipice, and this is the opening paragraph from the chapter in my book on understanding moving from thoughts of suicide to suicidal behaviour. And it's a heartbreaking quote from a mother whose son took his own life. I never thought he'd do it. A few weeks before his death, he had told me that he had thoughts about being dead, but I was too scared to ask him directly whether he would kill himself. I haven't stopped asking myself why. What I didn't ask him. Not a day passes when I don't torment myself with this question. When I look back on it now, I just didn't think he was the type of person who would kill himself. I know how ridiculous that sounds, but he was just always so full of life. And as somebody who's been twice bereaved by suicide, and many of us in the audience will have been bereaved, this is just a heartbreaking message, and it illustrates the challenge we face. We need to better understand this transition from thoughts of suicide to suicidal acts. So again, in my model, I've tried to answer that question or address that question. So this figure here is just, if you think back to my picture of my model, the picture of my model on the right-hand side, the volitional phase. And that volitional phase is, remember, understanding this transition from thoughts to acts. So all I've done is blown up those key factors into a diagram which I hope is more easily understandable. So we've got here on the left-hand side, suicidal thoughts and intent. And on the right-hand side, we've got suicidal behaviour. And those 8 factors in the middle are these volitional factors. And these volitional factors are the ones which I'm saying are key to understanding this transition. And so it's relatively straightforward. If you're thinking of suicide and you've got the ready access to the means of suicide, you're more likely to act on your thoughts. If I look at another one, the third one, exposure to suicide or suicidal behaviour. So if you know somebody who's died by suicide, if you know somebody who's attempted suicide, you're more likely to act on your thoughts of suicide. Now, it's important, though, to caveat that. That's a statistical increase in risk. The overwhelming majority of people who've been bereaved, or the overwhelming majority of people who know somebody who's attempted suicide, will never become suicidal, will certainly never attempt suicide or die by suicide. But it's an important risk factor. Or the more impulsive you are, the fourth one, the more likely you are to act on your thoughts. I'll just do a couple more for the purposes of today. These next two, physical pain sensitivity and fearlessness about dying or death, this idea is that people who attempt suicide have to overcome often physical pain tolerance to actually carry out the suicidal act. So we think that people who attempt suicide or die by suicide have higher physical pain tolerance. And we also think that they have to overcome the life instinct and they're less fearful about dying. And Thomas Joyner in the United States talks about both of these factors as having the capability or the capacity to die. And so the key message, though, is these factors on these volitional phase factors are key to understand the transition between thinking about suicide and acting on your thoughts of suicide. And so the message is that the factors that lead you to become suicidal, things like defeat and entrapment, they're important in the emergence of suicidal thinking, not on whether you make that transition. And so indeed, in another study in Scotland that we conducted, we looked at this in one of our in a research context. So in this large sample, we were able to identify people who have thought about suicide and those who have attempted suicide. And remember, and all I'm going to do in this study is I'm going to compare those two groups of people, the people who think about suicide, the people who attempt suicide, on these key driving factors, on these volitional factors and these motivational factors. And if my model is to be supported, it's the volitional factors which are important in that transition. And indeed, that's what we found. So if I just look first of all at the motivational phase. So these factors in defeat and entrapment, although they're important in somebody becoming suicidal, they're not crucial in differentiating somebody who thinks about suicide from somebody who attempts suicide. However, when we then move on to the volitional phase factors, the people who attempt suicide are more impulsive. They've higher capability for suicide. They've more mental imagery about dying and death, and they're also more likely to know a friend who's attempted suicide. So it's what's really important to think about here is these volitional phase factors are key in understanding that transition. And the ones that surprised was two factors which we thought may come out as different didn't. So knowing having a family member who's attempted suicide or knowing somebody who died by suicide didn't emerge as important. But the reason we think that didn't come out as significant is because this is a young adult sample, and young adults, we think their behaviours are much more influenced by their peers and friends than they are by their family members. And we've done countless other studies looking at this, and there's lots of data across lots of age groups and populations supporting this importance of the volitional phase. Okay, in the last 5 minutes, I'm just going to say a couple of words on this interventions, how we can intervene to interrupt the transition from suicidal thoughts to suicide attempts. So again, a few years ago, we published an update. We published an update on the evidence base on what works. And the good news is we look at these psychosocial factors, or these psychosocial interventions, there's lots of evidence that they work in the context of preventing suicidal behaviour. So the longer term interventions like cognitive behavioural therapy, there's evidence it works, but there's also been this growing focus on these brief interventions, and these brief interventions such as safety planning. And safety planning is widely used in a clinical context, but up until pretty recently, it was unclear what the evidence said, whether it was effective or not. So I'm just going to say a few words about safety planning and then draw it to a close. So we published very recently a review paper looking at the evidence base for whether safety planning was effective. And again, don't worry about the details of this. It's all available on our website if you want to know more. But the take-home message was that there's a small number of studies have been conducted internationally, but the evidence is clear. Safety planning is associated with reduced suicide attempts or suicidal behaviour over time. And indeed, in Scotland, we've looked at safety planning in the NHS context in the UK. So a safety plan, there's lots of different ways in which people do safety planning, but in essence, it's got 6 steps, as you can see blurrily in this left-hand figure. And we've conducted a feasibility study in Scotland, and that feasibility study is, we're not just looking at safety planning, we're looking at safety planning which is administered to people who attempt suicide in the emergency department, and then we also offer people up to four or five telephone calls over the next 4 weeks. Because the whole point of that telephone calls plus safety planning is when we know, the evidence tells us that people's suicidal behaviour risk is highest in the days and weeks following an index suicide attempt. So we should be doing as much as we can to help people feel connected and supported in those weeks. Now, ours is only a feasibility trial, so we couldn't tell whether it's effective, but all the data were incredibly positive. That it is possible to properly embed a safety plan, which is a dynamic document, not a static document. It's a document which is completed collaboratively with people who are suicidal, but crucially, it works well, which seems to work well in the context of having ongoing telephone support for the short term. Okay, just to bring it to an end and hopefully have a time for a few questions. The other thing to note before I finish is the importance of safety plan being one of those areas, one of those things that's more than that document. It's more than that 1 page of A4. It has to be delivered compassionately in collaboration with the patient themselves, or the individual themselves. Okay, so what I've tried to illustrate in the last 30-ish minutes is to think about suicide as about this ending pain rather than ending one's life. And that if we are to tackle and prevent suicide, we need to look beyond mental health problems, because suicide is a public health problem, which is huge social drivers to the suicide risk. And we need to tackle inequality, stigma and discrimination. And we need to be vigilant as we now move out of and recover from COVID-19 and support each other to provide compassion, but also to be compassionate to ourselves, and collaboration across individuals with lived experience, with people providing support, with family members, with politicians and clinicians around all of us is crucial. And then the last point is I've tried to make the case that the factors that lead somebody to become suicidal are different from the factors that lead somebody to attempt suicide. And so I just want to end with the last few lines of my book. And it's really important, this message, I think, today on World Suicide Prevention Day, when we are trying to create hope. Although we can never bring back those who we have lost, we can better support those left behind. And if we work together, we can save more lives. My ultimate hope is that, as a society, if we are kinder and more compassionate, both to ourselves and to those around us, then we'll go some distance in protecting all of us from the devastation of suicide. Thank you for your time.
Thank you very much, Rory. Absolutely fantastic presentation, very thought-provoking there. It's very strange doing these things on virtual means, because I'm sure there'd have been a round of applause and a standing ovation there, Rory. But I think we can see certainly through the chats and through all the applauses that are coming through on the teams right now, how much that has meant to everybody. I'd just like to mention as well, because it was it's quite a subject that we're talking about at the minute, trying to choose our words carefully. And we said right at the beginning that if anybody does need any support during or following today's event, please visit our No More Suicide website, which does have a range of help and support. And we'll put the link in the chat there for you. So we've had quite a few comments there for Rory. And to be fair, it was quite a comprehensive presentation. So a lot of the questions may have been answered, but we do have one I saw here from Sue Forster, and she asks, in one of her areas of work, she has a high risk location with between 2 and 5 people attending per week. She'd really like to understand, how do we do interventions to stop regular attendances and those that are impulsive and transactioning from thought to act, and how does the high profile of the high risk location in the media affect those who are vulnerable in the community?
That's a brilliant question. Such an important question. I'll try and say a couple of things on that. The first is in terms of safety planning. So safety planning plays an important role on an individual level in that context. So if, for example, you're working with somebody who is suicidal and they're thinking of that area or that means of suicide that's just been mentioned, what you're trying to do is work collaboratively with that person to try and increase the distance between that person, both physically, psychologically, environmentally, and that method. So that could be working with them to go, well, if it's an area of concern, a place of concern, maybe which is close to the place of where they work or go to shops or something, you try and get the person to work so they go for a different way to work or to shopping, whatever it may be. At the level then of media coverage, we know for certain that media coverage, if it's done in a way which is describes detail of the method, that is associated with increased risk of suicide. So it's why it's important that the media guidelines, which are published by, there's guidance by the International Association for Suicide Prevention, Samaritans and others, about how we should talk about and report these suicides. And because it's finding that balance between communicating to challenge stigma, but not facilitating an area of concern. So it is that balance, but there's guidance out there, and I really encourage all media to adhere to that guidance. And if you're working in the context of an organisation, write to your local representative and ensure that it is to put pressure to these guidance are adhered to.
Thank you very much, Rory. I'm sure that answers Sue's question. Thanks very much. Just trying to scroll through. There's that many comments and questions on the chat. It has been brilliant. But there was one quite early on from Sandy Maguire, and she says it feels like we need to front load suicide prevention strategies into schools, giving young people across the whole spectrum strategies to cope with such overwhelming feelings, which may not surface until adulthood. You probably picked it up in your presentation, Rory, but I just thought I'd mention it in case you want to make any comments now.
Yeah, no, because that is an important one. The schools context is a complicated context. So so I wouldn't advocate doing suicide prevention specifically in schools, but what I would be advocating and what we do advocate is exactly what was behind that question, is dealing with emotional problems and how we respond and regulate and so on. Because there is some evidence that if you're talking directly about suicide in schools, it can lead to increased distress in young people, which is obviously not what we want. So in Scotland, actually, we're doing work on what's known, it's called the Distress Brief Intervention Programme. We've just extended it to schools, and we're piloting it in schools. And it's a way in which young people can get support within 24 hours if they are in crisis, or not in acute crisis, but if they're in distress. So I think it's a really important area, but we need to be careful how we manage that.
Okay, thank you very much. And then trying to rattle through some of these so we can cover everybody's questions. Pamela just put in the question there, which is quite long. I want to read it to you now. It's from a preventative point of view, what is the most evidence-based approach to preventing suicides in areas with poor determinants of mental health and suicide risk factors? How would you address self-harm, especially in view of the increasing poor emotional and mental health of children and young people? So a little bit of an overlap from the last one for you, Rory.
Yeah, and again, covering a really important topic. So I don't think we know for certain what's most effective in areas with loads of determinants of suicide risk. But if you look at it, the question is, what is the most effective way of preventing suicide in terms of evidence? It's restricting access to the means of suicide. That's the most, these large public health interventions where we restrict access to areas of concern or put helpline numbers on it. That's the evidence-based first and foremost. But I think you're right. I think we need to look at how we, there's lots of good examples like of areas of innovation, which you're trying to tackle that inequality. Because for me, I always ask the question, as I said in my presentation, anything we can do which tackles the sense that somebody will feel defeated or humiliated or shamed or not valued, that what we need to do in those areas is build up people's self-esteem, build up, help protect them from often this early life trauma they will have experienced. So I think we don't have the right answer just yet, but I think recognizing that is the first step, and then the resources so people do get the help that they need. And you mentioned young people in self-harm. I think it is a big challenge we face, because the reality is that we know for certain pre-pandemic that young people's mental health was getting worse. And then at the same time, and that includes for treatment for self-harm or support for self-harm, but we also know that waiting lists have got longer. So child and adolescent mental health services, which is not the solution for everybody, but the challenge is we just don't have quick enough access, and that is an absolute disgrace.
Here. Yeah, 100% agree with you. And I suppose everybody in this room would echo then comments too. We're kind of coming to the end now, Rory. So I think we've had quite a lot of comments in there saying how much your presentation will change their thinking and change the way that they will do things, and that is exactly what we wanted to do. We said at the beginning of this process that it wasn't just about writing a strategy, but it was about delivering change. One thing I might just abuse my position as chair, if I may. It's great to have you virtually, Rory, but we would love to invite you to a physical event in the near future as soon as we can. I'll leave that up to the people who can arrange it. But it'd be great to meet you in person, and I'm sure everybody here would love to come and see you physically. And I'm not on commission, but I'm sure if you can put a little link to where to buy your book, I'm sure a few people might want to purchase it and have a read. So thanks very much for your time today, Rory. It was brilliant to hear you. Thanks for taking the time to speak to us all today.
Not at all. Thank you so much, and enjoy the rest of your day. And as I say, apologies, I've got 4 more talks to do today, so I have to run. Thanks, and best of luck.
No worries. Thank you. Take care.
Bye-bye.
Great, it's absolutely fantastic. Sorry, just flicking on slides here. It's absolutely fantastic to hear from Rory O'Connor there. I'm sure you'll all agree, and we saw all the comments coming through there. We should have had the break after Rory, to be fair, because there's a lot to take in. But I do hope that the team from Champs can work together and get Rory down here. It'd be great to have him in a venue in the region, and then we can expand that and really ask him some good questions, because I do think 10 minutes perhaps wasn't long enough, but maybe we can work on that next time. So it's over to you now for our engagement session, and one person who I forgot to introduce earlier, how could I forget Sue? Now Sue Forster is going to introduce us to the group work, and Sue is a public health consultant who's worked in public health since 1993, working across Lancashire and Cheshire and Merseyside. I'm very pleased to say I had the pleasure of working with Sue over in St Helens as our Director of Public Health. It's great to see you again, Sue. And she has dedicated much of her public health career to challenging and working to address the very complex issues of suicide and develop plans and strategies to drive forward change. Sue has personally been affected by suicide and self-harm and has lived experience of the impact on family and friends, and therefore she still feels that there is much to do to ensure that Cheshire and Merseyside have the best outcomes in this field in the country. So Sue, over to you, and you can introduce the group work.
Thank you very much for that fantastic introduction. I can't tell you how this morning has really been fantastic. Rory's international experience is just second to none. And then the work that we've been trying to do locally, and some of that real local learning, especially around men's health, is just fantastic. But we do have Cheshire Mersey suicide prevention, the No More strategy, that is now needs to be refreshed. And this time we really want to look at really engaging with a lot of people and have it owned right across the system, because you will hear that really to make a difference, we need a lot of people involved in this area of work, because the risks of suicide we know are complex. So we need everybody to sort of play their little part or big part. So what we're going to ask you to do now is, because there is a lot of us on this session, it was difficult for us to do nice little breakout rooms with facilitators. But what we are going to do is break you into rooms. You will be automatically broken into those rooms and sent on your way. I would ask that one person scribes some notes, and we just generally talk about what we think has gone well in the past few years in terms of our strategy, and we need to continue doing. So what are we doing well and we need to do more of or continue doing? And what do we feel are the top 3 priorities? We will do that for 20 minutes in our session, and then we'll come back and do a wider mentee, which we'll follow you through and tell you how to do that. So now I'm going to ask that our people behind the scenes sorts our groups, and we go. Please, we will tell you any notes that you've scribed into stamps, and we'll do that at the end. So thank you all for your work and the work that you're going to do now. Thank you.
Okay, I think everybody should be just arriving back now with us. Just give it a minute or two just to make sure. Okay, well, while we're waiting, actually, because the slide is there, we're now going to do some mentee feedback. You can see the instructions there on the screen. If you could visit www.mentee.com on your mobiles or on your PC and type in the code, which is in the chat, which I think is 81302165. And in there, you can enter your top 3 priorities for the new strategy. So we give people a few minutes to do that, and then we can collate all that and see what it looks like. Sure, Councillor Cernick. Apologies, I don't think everybody came back when I said it before. So yeah, we're going to ask people if you can visit Mentee, www.mentee.com, either on your mobile. I think you should be able to access it on the PC too. If you can type in the code once you get there, which is shown in the chat, which is 81302165. And then what we'd like you to do is enter your top 3 priorities in there for the new strategy. Once we've got a few things in there, we'll share the feedback live from Mentee, and then we can see what it all looks like. Hope that makes sense. Any questions, just pop them in the chat. We'll give you a few minutes to do that. Great, some fantastic things coming through there. We're getting the word cloud. Children support young people is very, very prominent. Bespoke CYP offer. Mental health support for bereaved. Quick access, very important. I think Rory mentioned that before in his summing up, didn't he? Collaborative work, something we do in the health sector, very, very good over in Cheshire and Merseyside. But yeah, collaboration is key, something we need to do across all sectors. So if there's any more, onto Mentee and the code. Sorry, there's quite a bit in the chat now. So it's 81302165. Yeah, and just why we're putting all these things in the chat, it's just to remind this is a very, very sensitive subject, and we'd just like to put another call out how important it is for all of us to look after ourselves in this area. And the professor mentioned it before as dealing with it day to day. You know, we really must look after each other. So please, if you do need any support at all, you can visit the No More Suicide website right now, which has a wide range of help and support. It's there in the chat. I'll copy and paste it so it's there again. And it would be great if you need to, if you could access that website there, and any help you may need will be there. Okay, we seem to have quite a lot there in the Menti now. And any last people want to add a few more? And we will capture all of this and make sure this is all part of the strategy too. So it's all very important. And we've got a couple more just coming in now. Just give another minute or so. The technology can sometimes be temperamental, can't it? Okay, I think the Menti will stay open. So if you do think of anything else, please do continue to input it on there. But just as we come to a close, first of all, I'd just like to thank everybody for your input into today's session. The speakers have allowed us to think about action, and the breakout sessions were a time to start the consultation journey for the new strategy. If you didn't get the opportunity to put your thoughts in the chat or voice your opinion, we will ensure that all attendees will at least receive a questionnaire to help shape our new strategy. As I said at the beginning, it's very, very important that this isn't just a tick box, a strategy document that sits on a shelf. It needs to be a living, breathing strategy of action shaped by us all to deliver our target of 0. So I hope that today has motivated you to take action in your own way to prevent suicides. We know we have already made a huge difference in Cheshire and Merseyside with the collective action of all of us, and will set Cheshire and Merseyside apart to be the best, safer suicide community in the country and beyond. But we'll only do that if we work together. So thank you to our absolutely fantastic speakers, to Ruth du Plessis, to Michael Salla and Professor Andy Smith, to the brilliant Professor Rory O'Connor and Sue Forster too. But this event wouldn't be possible without the fantastic support from the team from the Wirral. So a huge thank you to Jenny, Tracy, Helen and Lucia, and Neil too. Apologies if I've missed anyone. I've tried to get everybody on that list. But first of all, thank you to all of you for joining. Creating hope through action is our theme. Collective action together can change despair to hope. Hope you have a lovely weekend, and thanks very much for joining. Take care.